Hello, so this first lecture we're going to go over is just ovarian cancer basics, going over the different cell types and coming up with a differential for ovarian cancer. I feel like in medical school we don't touch on this enough, and then you come on your rotation and you're expected to know several different types of ovarian cancer, so we'll go over those today. So the three main cell types are epithelial, germ cell, and sex cord stromal. Epithelial being that outer layer of the ovary, germ cell being the reproductive cells of the ovary, and sex cord stromal being the stromal cells of the ovary. And so under our epithelial category, the main types, and there's always rare types in each of these categories that I'm not going over today, but the main histologic subtypes are serous, mucinous, endometrioid, and clear cell. And I tried to label in this picture the different cell types with 1 being epithelial, 2 being germ cell, and 3 being sex cord stromal. And I hope you like this one and only, one of a kind depiction of the ovary that I drew here. Germ cell histologic subtypes include teratomas, dysgerminomas, embryonal, yolk sac, and choriocarcinoma, just to name a few. And then your sex cord stromal tumors include granulosa cell tumors, Sertoli Leidig's, thecomas, and fibromas. And when you look at the breakdown of the prevalence of ovarian cancer, you see that the different subtypes make up different percentage, with epithelial being about 95% of what we're going to see. Germ cell in the second category with 4%, sex cord stromal about 1%, and then there, like I said, there are some other rare tumors in there. Epithelial ovarian cancer, we went over some of the categories, and just to further break these down, serous, high-grade serous is the most common, but serous in general will make up 75% of these tumors. Serous breaks down into high grade and low grade, and these are two separate tumor types. They have completely different molecular features, therefore making them completely separate tumors. Mucinous tumors, these will show up usually as large masses, and you can see an elevated CEA for these tumors. And then your endometrioid and clear cell, these are two types that can be associated with endometriosis. And clear cell is interesting, as you can see an increased incidence of DVTs with clear cell. And so this entire category of epithelial ovarian cancer embryologically originates from primitive mesoderm. And it's believed that, at least for our serous types, that these arise from the fimbria of the fallopian tube. We have our tumor markers over here for epithelial ovarian cancer types. CA125, or cancer antigen 125, is derived from the peritoneum and elevated in epithelial ovarian cancers. This is more specific for postmenopausal patients. It can also be elevated in benign conditions, and so our usual cutoff for a CA125 in a postmenopausal female is 35 or less. We then have our CEA. This is carcinoembryonic antigen. This is present in the colon and can also be present in mucinous tumors. And then CA19-9, which is cancer antigen 19-9. This can be seen in appendiceal cancer, but can also be elevated in mucinous tumors. We then move on to our germ cell tumors. These are derived from primordial cells, otherwise known as the cells that become spermatozoa and oocytes, or, as I mentioned earlier, the reproductive cells. These tumors are most common in young women and adolescents. The tumor markers include AFP, LDH, and HCG. These tumors are very chemosensitive, and as you can see on the right, your typical chemotherapy regimen for germ cell tumors will be BEP, or bleomycin, etoposide, and a platinum, usually cisplatin. Teratomas are your most common germ cell tumors. These are usually benign. They can include all 3 cell layers, teeth, hair, and fat. And the reason for removing teratomas, even when we consider that they could be benign, is that there's about 0.2 to 2% of malignant transformation into squamous cell carcinoma. Dysgerminomas are your second most common type. You'll typically see LDH and HCG elevated. I like to think of the D in LDH and the D in dysgerminoma. And then you have yolk sac, embryonal, and choriocarcinoma with their respective tumor markers listed there. Lastly, we have sex cord stromal tumors. These originate from ovarian stromal tissue. The average age of a patient with these tumors is around 50 years old, and these tumors are known for secreting hormones like androgens or excess estrogen. They often show up as solid masses on imaging, and lymph node metastases are very rare in these tumors, and therefore lymph node dissections can be avoided. Granulosa cell tumors are tumors that can secrete estrogen. Due to that, you must do an endometrial biopsy when these are diagnosed. Inhibin A and B are the tumor markers that can be elevated with granulosa cell tumors, and your typical buzzword for granulosa cell tumors are Call-Exner bodies, and this is what you would see on histology. And so in my residency, one of my senior fellows made this little call your granny for Call-Exner bodies and granulosa cell tumors. And then Sertoli-Leydig, these can secrete testosterone, and you may see androgenic effects in these patients. And something that you may see on histology for these tumors are cells of Ranke. And that concludes our ovarian cancer basics. Here are my resources, and you can find me on YouTube or Instagram. I hope that this was a quick overview for you. Have a great day.